on to one of the most relevant topics in recalcitrant glaucomas in patients who have posterior segment pathologies, which is the IOP elevation that we see after intravitreal injection. In this era where the anti-VEGF injection or steroid injection has become the standard of care in the management of retinal vascular pathologies, we need to be aware of the fact that the intraocular pressure elevation, which can occur after intravitreal injection, may occur in the immediate post-injection phase, or it can be a sustained elevation of intraocular pressure. These are the common indications for which anti-VEGFs are given in any retinal practice. And if you look at the IOP elevation after anti-VEGF injection, it could be a prompt volume load related post-injection elevation or the transient IOP elevation, in which the IOP increases sky high in the immediate post-injection phase and then returns back to normal without any treatment in about 30 to 60 minutes time. This is basically because of the volume overload. In contrast to that, we have a group of patients who develop a sustained increase in intraocular pressure because of various factors, some of which are known and some of which are unknown. And this sustained elevation of intraocular pressure could be defined as an IOP which is more than 25 millimeter of mercury, or a 5 millimeter increase in intraocular pressure from the baseline value, that the value we started with before giving the intravitreal injection, or when there is a 5 millimeter difference between both the eyes. As we go through the talk, I will try to elaborate on the various mechanisms which are responsible for both the transient as well as the sustained elevation in intraocular pressure. So transient IOP elevation, the IOP may go as high as about 30s or even 40s, and this increase in intraocular pressure is actually quite alarming because we are very worried that this transient elevation of the intraocular pressure could cause an aggravation of the ganglion cell layer, the optic nerve head damage in an eye which has already a compromised posterior segment. So we do not know whether routine paracentesis is necessary in all these patients or whether these patients need IOP monitoring till the pressure returns back to normal. This transient high IOP elevation could be associated with two very extremely rare but dreaded complications, that is a blowout of a trabeculectomy bleb, or some of these patients, when a lot of volume is injected into the vitreous cavity as a bolus, can push the lens iris, hydrate the vitreous and push the lens iris drive from forward, and there has been instances when this has resulted in an acute angle closure attack. If you look at the volume-related transient elevation of intraocular pressure and its influence on the mean ocular pulse pressure, you can see that immediately in the post-injection period, the mean ocular pulse pressure is reduced. Perfusion pressure is almost reduced to half of what we had in the pre-injection phase. But bear in mind that the optic nerve head has a very The optic nerve head had a very efficient blood flow autoregulatory mechanism, and when there is a reduction in the mean ocular pulse pressure, it is compensated by a reduction in the vascular resistance, so that there is more blood flow occurring both to the optic nerve as well as to the peripapillary retina. If you look at the factors that have a correlation with the transient elevation in intraocular pressure, it is correlated significantly to the baseline IOP. It also increases more when more number of injections at a shorter duration of time has been given to the patient. A smaller axial length, which should definitely have a correlation, has been found to have no positive effect in various well-constructed studies, and when the interval between injections is reduced, the transient elevation of intraocular pressure is also more. There is a definite correlation between the need of the gauge of the needle that we are using for injection and the way you inject into the eye. And if you look at this video clipping, it shows that following the injection, when you have injected a bolus of the drug into the vitreous cavity, there is some reflux of fluids into the subconjunctival space, which is called the post-injection reflux. The post-injection reflux is a very important safety mechanism which helps the pressure from going up sky high and resulting in dreaded complications such as a central retinal artery occlusion. And most of us have the knee-jerk reflex of trying to prevent the fluid from coming into the subconjunctival space by pressing on the site of injection. This is something which should not be done. If you are using a smaller gauge needle, and if you are puncturing the globe and injecting deeply into the eye, the post-injection reflex will be less, and that can result in a very high transient elevation of pressure. This is actually a safety valve mechanism which should be encouraged in your subjects. If you're injecting by a tunnel entry into the vitreous cavity, or if you're injecting deep into the vitreous cavity, the PIR will be less. Prior massage of the globe to reduce the intraocular pressure has no effect. Ocular decompression does not have any effect. Prior administration of anti-glaucoma medication, either in topical or oral medication, has no effect in the transient elevation of intraocular pressure. But there is one method which can significantly lower the post-injection spike is to perform a paracentesis, which will ensure that adequate volume of the drug enters the vitreous cavity. And whenever you are dealing with a patient with primary open-angle glaucoma who already has disc and optic nerve head changes, it is better to do a paracentesis each time you inject into the vitreous cavity. When you are doing a paracentesis routinely, we will be letting out about 210 microliters of aqueous, and this decreases IOP, prevents a post-injection reflex. It also ensures, in this situation, although the post-PIR is a safety phenomena, in this situation when the eye is softened and there is no efflux of fluid from the eye, it ensures that whatever drug that you're injecting into the eye remains in the eye and becomes more efficacious. So routine prophylactic IOP lowering medications are not necessary. Frequent monitoring of IOP till normalization of pressure is also not necessary, except in patients who have a very compromised optic nerve head and very high pressure spike. We look at the second aspect, which is a sustained elevation of intraocular pressure. And if you look at the sustained elevation of intraocular pressure, the definition is different in different studies. And if you look at the post-ad hoc analysis of RCTs, where there is definitely no definite criteria on what is sustained elevation of intraocular pressure. The incidence is about 26.1%, but in real-world settings, we rarely ever see a sustained elevation of IOP following anti-VEGF injection, and it's about 4.7%. The various postulated risk factors for a sustained elevation of IOP are increased duration of treatment, more number of injections, lesser interval between injections in patients with primary open-angle glaucoma, and there is no role for the type of drug that you inject, whether you inject bevacizumab, Avastin, aflibercept, combacept, or Paginax, whatever you inject, there is no definite role on the type of drug and the protocol of injection. If you're following a treat and extend protocol, or you're injecting monthly, or you're a PRN basis you're injecting, it has no role on the sustained elevation of IOP. When the duration of treatment and the number of injection increases, there is more chance for development of sustained elevation of intraocular pressure. Let us look at this example of a patient who has a non-ischemic central retinal vein occlusion and macular edema. He received 3 injections of Lucentis. We started with the baseline IOP of 20 millimeter of mercury, and at the end of 3 injections, his IOP has gone out to 24. His fields are normal. Interpretation of the fields in patients with already a compromised retina and retinal pathology is difficult because the glaucomatous changes as well as your retinal changes contribute to the fields that you bring out, and it's very difficult to interpret. So the post-IVB spike of 24 millimeter was not associated with. Geo seems to be very interested in connecting with me. Was associated with the normal static field and no RNFL changes, so we just kept this patient on follow-up. Let us look at another example where the IOP elevation from baseline was about 10 millimeter after the patient received 3 injections of Avastin. This patient had no family history of glaucoma and no history of prior treatment for glaucoma. His central corneal thickness was 575 micron. There were no field or RNFL changes. We just put him on brinzolamide eye drops in the hope that his pressure would come down further, and also giving topical carbonic anhydrase inhibitors may contribute to resolution of his macular edema. So he did well with that. Let us look at the mechanisms which are responsible. The most important mechanism is the microparticle obstruction of the trabecular meshwork and trabeculitis. This is...
Excuse me, can you just convey the information? The sessions are still going on, and they have no business to start rehearsal for drums for the evening event. Please tell them. I'm trying to contact them, but they're not picking up the phone.
Am I audible? If I am audible, we can let them enjoy and finish our work. The most important is the progressive increase in the number of microparticles, especially with bevacizumab, if the whole time is longer.
Hello, sir.
We usually keep the bevacizumab injections stored for about 14 days, and we injected it as and when the patient comes in. And as the whole time increases, the number of microparticles also increase, and this can block the trabecular meshwork. So also silicone leaching from the syringes that we use could also be responsible. The anti-VEGF that we inject into the eye has a direct toxic effect on the trabecular meshwork cells by reducing the action of the nitric oxide synthetase. And VEGF is a substance which is actually produced by the Schlemm's canal. And when you inject, and it contributes to improving your facility of aqueous outflow. And when you're injecting anti-VEGF into the eye, you may block this action of VEGF and thereby produce an increase in the intraocular pressure. Chronic anti-VEGF administration has hence been associated with a reduction in the facility of aqueous outflow, and also some amount of RNFL thickness changes have been seen, especially in diabetic patients who receive multiple injections. So let us look at a patient who has an elevation from baseline, and he again develops a recrudescence of macular edema. And in this situation, what will you do? We will note the presence of sustained IOP elevation in the case sheet. We'll consider an AC tap paracentesis before injecting the next time. Continue stepping up his anti-glaucoma medication. Follow him up closely and see to it that each time he comes, every 3 monthly, you repeat his fields, OCT and RNFL changes. The second part of this presentation is on intravitreal steroids, which are very effective inflammatory mediators. The IOP elevation caused by steroids is actually misrepresented, and this very good drug is less commonly used. If you have a patient who has ocular risk factors, such as he has primary open-angle glaucoma, or is a close relative has a close family history of primary open-angle glaucoma, he has type 1 diabetes, he is a high myope, older age group, or very young patients, and patients who have had prior steroid response, especially if the IOP spike has been more than 15 millimeters. These are all the ocular risk factors, and when we are giving intravitreal steroids in these patients, you should keep this in account. So a patient here is on known case of primary open-angle glaucoma on Lumigan. He has a recent myocardial infarction where anti-VEGF injection is a no-no. Baseline IOP is 18 with 2 injections of Osiodrex. His pressure increases about 8 millimeters around the baseline. So we step up his anti-glaucoma medications. So the incidence of the most commonly used intravitreal steroid right now is dexamethasone. We give it in the form of dexamethasone implant. And post-implant high IOP spike, do not take a single reading as a risk for elevated intraocular pressure. Keep your patient on follow-up. Look at the pressures in the other eye. See if correlate his pressures with the central corneal thickness. Look for asymmetry in the cup disc ratio and difference in pressures between both the eyes before coming to a conclusion that the steroid that you have injected is responsible for the elevation of intraocular pressure. Steroids causes elevation of intraocular pressure by a variety of mechanisms. Most important is stabilization of the lysosomal membranes. And what it causes is that it causes accumulation of glycosaminoglycans, which swells up and causes a biological edema and clogs the trabecular meshwork. In addition to that, the injection of steroids can cause stiffness, both of the trabecular meshwork cells as well as the trabecular meshwork, reducing the facility of aqueous outflow. There is, there is inhibition of phagocytic properties of the endothelial cells, so your trabecular meshwork gets clogged up with debris, and also decrease in the synthesis of prostaglandins, which is necessary for aqueous outflow from the trabecular space. Steroids produce some amount of cytotoxic effect on the trabecular meshwork cells. It causes increased release of LDH and Cas spaces. That probably it causes an increased apoptosis of the trabecular meshwork cells, which could again be responsible for your changes. So if your patient who has IOP of more than 8 millimeters above the baseline, again has recurrence of macular edema, would you consider a second implant in this patient? Studies have shown that you can definitely give a second implant because most of these situations can be medically controlled. And there is no predictability as to which patients will develop a post-op spike after a steroid injection. Topical steroid, corticosteroid challenge test has very little role. You look for ocular and drug-related risk factors and decide whether your patient requires an anti-inflammatory mode of therapy to manage the VEGF, manage his posterior segment condition, or VEGF is responsible, and decide and inject accordingly. I thank you very much for your patient hearing. I have one more short presentation on this is also very relevant because peripheral exudative hemorrhagic chorioretinopathy in an elderly is very infrequently diagnosed but commonly encountered condition, and awareness of this condition, especially in your patients, majority of our elderly patients are on anticoagulants. They could be on a single anticoagulant or two anticoagulants. Almost everybody is on aspirin and clopidogrel these days. So in this group of patients who have peripheral exudative hemorrhagic chorioretinopathic changes, even subtle changes can develop massive suprachoroidal hemorrhage and angle closure. I'll show you two patients whom I saw in my practice. If you look at the causes of acute angle closure glaucoma, because of massive suprachoroidal hemorrhage, this is the literature review, so far gives about 22 cases of various causes ranging from age-related macular degeneration, anticoagulant intake, chronic myeloid leukemia, PCV. PHCR has not been so far reported, so I thought it would be interesting to put this forward so that an awareness of this condition. It is a very frequently seen condition in a retina practice, and any one of our patients who is on anticoagulant therapy has these risk factors. This is an elderly man who was referred to me for management of an acute congestive attack. And you see that his chamber is very shallow, cornea is steamy. If you examine his fellow eye, you can see that he has areas of subretinal hemorrhage and other changes suggestive of PHCR. This is at presentation, and 1 week later, he underwent drainage of the suprachoroidal blood. Most of these patients do very poorly, and most of the time the eye ends in phthisis, but drainage of suprachoroidal blood ensures that the patient is comfortable for some time into the postoperative period. This is another such patient. If you see his fellow eye, these are the classical changes of peripheral exudative hemorrhagic chorioretinopathy in the elderly. Small, subtle areas of subretinal hemorrhage with pigmentation, drusenoid material will be seen at the periphery, and most of these changes, patients will not have age-related macular degenerative changes in the fundus. In this patient also, we drained the suprachoroidal blood, and eye became phthysical. The cut down is done, the choroid is exposed, and using a spatula, the suprachoroidal blood is leaked out. So friends, I thank you very much for your patience in remaining here with me. I hope the session was interesting, and thank you very much for your patient attention.